Dr. Bob Reiter is invited to take us back to Gleason 6, adenocarcinoma of the prostate, please.
All right, thank you. I want to thank Lori and Kobe for the kind invitation. It's great to be back in Israel 2 years after the first meeting. So I'm going to go back to many of the things that were really touched upon earlier by both Lori and Jonathan, and also in some of the questions, which is the question of how do we predict, or can we predict, progression of patients who by biopsy at least have Gleason 6 disease. So I'm going to stay away a little bit from the argument as to whether Gleason 6 is cancer or not. So if I can figure out how to move forward. All right, so I think there are three assumptions we make based on, at the time of diagnosis using biopsy, in terms of who could be a good candidate for active surveillance. That is, who truly has this low-grade, low-risk disease, whether it's cancer or not. And it assumes three things. Number one is that Gleason grading is accurate and reproducible. That's really not something we really touched upon earlier, but I think one of the problems is that the definition of Gleason 6 has become stricter and neater because of work by Jonathan and others over the last 10 years, last decade. However, I'm not sure, and I think there are many articles showing that there's still somewhat of a lack of consistency around the world, certainly around the US, in terms of actual grading based on biopsies and even radical prostatectomy. So number one, we've got to assume that Gleason 6 is Gleason 6 is Gleason 6. Number two is that Gleason grade 6 tumors are not biologically active, which we touched upon. And number three, which probably is the larger of the problems that we face right now, is whether staging and grading on biopsy are accurate. That is, how do we identify the 20 to 30% of patients who are currently understaged or undergraded? By the same token, how do we identify those patients who could be good candidates for active surveillance, who right now are not identified as such on biopsy because they have maybe 4 cores of Gleason 6 as opposed to 2 or 3. So I'm going to try and tackle those. So Lori introduced this great case from Johns Hopkins of a man who was diagnosed 17 years prior to his death from prostate cancer. Really interesting biology here, but the end of the day, I think the take-home point is that you can't predict the biological activity completely based on a histologic description of cancer, since in this case, although it was part of a very large high-grade tumor, the actual clone that killed this gentleman was present within a Gleason 6 focus. So I think clearly that gets the issue that we need better ways to classify tumors than histology, because if we continue to do that, we'll be probably in the same place 10 years from now. So we've already heard introductions to the idea that if we could molecularly phenotype patients at the time of diagnosis, that is after biopsy, perhaps we could actually maybe even do away with histological definitions and really provide a molecular diagnosis and a molecular personalization of cancer. So right now there are many tests that are emerging. For use with biopsy, really, there are only 2 right now, Prolaris, which can be used in biopsy, although it was developed for radical prostatectomies. And as you heard, Genomic Health's Oncotype DX. There are actually many other tests that have been done but have not been taken up because they don't have commercial potential, haven't really been taken up by industry. And those are immunohistochemical staining for things like P10, P53, P27, Ki67. There are a large series of studies showing that loss or gain of these markers actually provides very good clinical and future diagnosis. Loss of P27, high Ki67, that is high rates of proliferation, do correlate with poor prognosis. And these are very simple to do and are out there already. So I think that one of the things we need to watch out for is that these very expensive new molecular tests, we need to determine ultimately whether they're better than simple immunohistochemical staining that's been around for many years, but unfortunately never really studied in a prospective, validated way for a number of reasons. So Oncotype DX gives what's called a genomic prostate score, but basically it's a 17-gene molecular assay looking at RNA expression of these genes. One of the nice things about it is it's not just focused on proliferation, but it actually encompasses a number of the molecular hallmarks of cancer. These are genes and biological pathways that have been identified as predictive of a number of different endpoints in the past, and then basically discovered and then put into this test by Genomic Health. It's actually a pretty cool test because you can do this on a biopsy with as little as 1 millimeter cancer. So it's actually a technological tour de force that the company was able to develop this. Okay, so what does it do? I think it's important to understand what it does and what it doesn't do. So it was developed as a way to predict final pathology on a radical prostatectomy. So it was not really developed to look at things like survival, which is a much longer endpoint. It was really developed to say in a patient on biopsy, could you predict who would actually have adverse features at radical prostatectomy? Specifically, any major pattern 4 or 5, whether or not the tumor was confined to the prostate, Gleason grade 6 or 7, that was extracapsular, but not actually Gleason grade 7, that was T2. So this is kind of a box that's still there and a question mark in terms of can you use this test to predict who has Gleason 7 tumors, which may or may not be aggressive. That's a question that remains to be seen. But it's important to understand what the test does and doesn't do. They've now published the study, but again, there were only 2 studies, so basically an initial study and then a confirmation study at UCSF. So this has only been done at 2 centers. We don't know how it performs on a wide scale prospectively, so there are some limitations. But clearly, this molecular assay does predict radical prostatectomy pathology independent of Gleason score. So in patients who have low-risk cancer by biopsy, this is a promising assay. Again, it predicts stage and grade independently of Gleason score. Another test out there, is Myriad's Prolaris assay. This is basically a test that looks at proliferation, given that proliferation is probably still a strong predictor of outcome. Basically looks at 31 cell cycle progression genes, normalized to housekeeper genes, and there have been a number of studies of this, and you can see that this is a study from UCSF, from Matt Cooperberg's group, showing that it stratifies tumors independent of CAPRA scores. So you could take a patient who had a very low risk tumor by CAPRA, and if they had a high CCP score, that identified patients at higher risk of progression. So certainly molecular assays are emerging. I think I would agree with the comment from earlier that they are A, expensive, and B, that we need a significant prospective and just we need to see how they perform in real time in real life. But these are now available. And then the final thing I'm going to talk about is MRI. This was also touched upon, how useful. MRI was a technique that was rejected and now is accepted so enthusiastically. And so we need to really look at how well it performs in terms of predicting which patients who have Gleason 6 cancer on biopsy actually may have worse disease. I think biopsy is something, it's in another session later today, so I'm not going to talk about this, that nowadays we don't have to do random biopsies alone. We could do saturation biopsies. You'll hear about that later by Dr. Crawford. You can do targeted biopsies where you can actually fuse the MRI and the ultrasound image quite easily with a number of technologies and actually biopsy lesions of high risk. So we've published now a study, which of course you can all look at. It was published in Urology last year, asking the simple question. It was a retrospective study based on radical prostatectomies. All patients at UCLA since 2004, so now more than 10 years, have MRIs done prior to radical prostatectomy as a way of planning surgery. So we were able to look back and ask a very simple question. Among patients who had low-risk prostate cancer on biopsy, defined by Jonathan Epstein's criteria, how well did Epstein criteria perform in terms of predicting upstaging or upgrading on final radical prostatectomy? And if we simply added one MRI parameter, that is diffusion, which is probably the strongest predictor among the multiparametric MRI parameters of the likelihood of a high-grade tumor, if we use that simple test, could we actually improve upon Epstein criteria to essentially weed out those who actually had higher grade cancers, that is, those who were at risk to progress. So this is the results of the study. I don't have time to go into all the details of it, but the bottom line is that Epstein criteria alone predicted low-risk cancer, as Jonathan said earlier. About 27% of patients who were thought to have low-risk cancer did not have low-risk cancer. We could argue about Gleason grade 3+4, but they had 3+4 or higher cancers that were measured at 1.3 centimeters or larger. by recent definition and consensus, that's considered to be a significant tumor. So Epstein criteria alone was pretty good, but missed about 27% of patients who were upstaged at the time of radical prostatectomy. Whereas if you simply added multiparametric MRI diffusion with a cutoff, which in our case was 850, it depends on the technology that you're using, what that cutoff would be, we could actually reduce the understaging and undergrading using histologic parameters alone from about 27% down to only 5%. So MRI clearly has potential. It's not perfect, and I'll talk about its imperfections, I think, in another talk I'm giving a little bit later today, but nevertheless certainly has the ability to help us identify who's more likely to have higher risk cancer and potentially progress than traditional histologic criteria alone. So, and actually I'm not going to talk about that right now. So I think in summary, basically what we have is I think we all agree that most Gleason 6 cancers are low risk, that current biopsy techniques that are so widespread understage and undergrade some percentage of men. Gleason 6 cancers are descriptive and don't really encompass biology, and that by using some of the new molecular assays as well as MRI right now in a place that has experience, we can certainly start to really reduce that understaging and undergrading, and therefore identify patients who really are optimized for active surveillance and really do have a very low risk of progression over time. So I thank you for attention. Thank you.